A lowercase a stands for arterial. So PaO2, lowercase a, stands for partial pressure of oxygen in the artery. Normal range is between 80 and 100 millimeters of mercury in arterial blood. PCO2 in the artery should be right around 40. It can range from 35 to 45. Okay? Remember the other day we said that if it's high, that condition is, if it's above 45, what do we call that condition? Hypercapnia. And it reflects the fact that you're hypoventilating, allowing CO2 to climb. It's not being excreted. On the other hand, if you're hyperventilating, then the CO2 is going to fall because you're getting rid of it at a rate faster than it's being produced. That condition is called hypocapnia, in which case the CO2 would be below 35. Bicarb is the buffer, the main buffer used within the bloodstream to buffer acids. We'll talk more about bicarb when we get to the digestive system. But its normal range is between 22 and 26, 22 to 26, and it's expressed in units of milliequivalents per liter. Milliequivalents. Has everyone taken chemistry and you understand the term milliequivalents as opposed to millimoles? Sometimes they can be the same, but it depends upon the charge on the atom or molecule. Did y'all understand what I just said? Or is that just...
Yeah, you said bicarb uses a buffer for what?
Well, the blood uses bicarb as a buffer. For instance, for acid. So for instance, if the hydrogen ion concentration climbs too high, bicarb can react with some of that acid and remove it from the bloodstream. So it's a buffer. And we said it's expressed in milliequivalents per liter because milliequivalents relates more to activity of ions as opposed to just concentration in millimoles. Okay? And then finally, the SaO2 is the hemoglobin saturation with oxygen. Normal is about 95 to 100%. Okay? Now, normal blood gases exhibit a pH between 7.35 and 7.45. If the pH is below 7.35, we say that the patient exhibits an acidosis. Now, textbooks can also use the term acidemia, but you'll never hear that term clinically. Everyone uses the acidosis term. On the other hand, if the pH is higher than 7.45, we say that the patient has an alkalosis. Okay, so that unlike other systems where neutral is 7.0, okay, in the human body we consider neutral 7.4. And so anything that drops below 7.35 is considered acidosis, even if it's 7.2. Anything that climbs above 7.45 is considered an alkalosis. Okay. Now, if someone has an alkalosis or an acidosis, then we say they have an acid-base disturbance or imbalance. Okay. And those acid-base disturbances can either be respiratory or metabolic in origin. So for someone who has an acid-base disturbance, there are four possibilities. They either have a respiratory acidosis, a respiratory alkalosis, or a metabolic acidosis, or a metabolic alkalosis. Now, since we're talking about the respiratory system, our focus is going to be on respiratory acid-base disturbances. We'll pick up the metabolic disturbances later in the semester. So let's talk about respiratory acidosis. Okay? This is caused mostly by impaired ventilation, rarely by impaired gas exchange that results in a buildup in CO2 within the body. Okay? So almost all cases of respiratory acidosis are caused by impaired ventilation, where we're not excreting the CO2 at the same rate at which it's being produced. So CO2 first builds up within the alveolus and then backs up into the bloodstream, and we're not getting rid of it. Okay? So the patient develops hypercapnia. How could this occur? Well, one common cause, if you work in the ER, is a drug overdose. Particularly a drug overdose with narcotics or barbiturates. They suppress the respiratory centers in the pons and medulla, and that results in hypoventilation. Okay? In fact, there's a triad associated with narcotic overdose that everyone who works in the ER knows. The triad is respiratory depression, meiosis is small pupils, and coma. Okay. So when someone comes into the ER in coma with respiratory depression, one of the first things we do is check their pupils. If they're small, then what moves to the top of our list is a drug overdose with a narcotic or barbiturate. In fact, that person is going to get Narcan, which is an antidote for narcotics, right away. And if in fact it's a narcotic overdose, suddenly they wake up and start breathing. It's like a miracle. Okay? So let's see what happens. We talked about this the other day. In the face of a narcotic overdose, because you hypoventilate, CO2 is going to climb within the blood. Remember, we said that CO2 can react with water, form a carbonic acid, and that will dissociate into hydrogen and bicarbonate. Okay. Now, if we have an excess of CO2, if we have hypercapnia, that pushes this equation from left to right, causing a buildup in free hydrogen. So that buildup then in free hydrogen is going to lower the pH of the blood. So that person with a drug overdose may come in with a pH of 7.2 in association with the CO2 of, let's say, 54. Okay. Let's just make up some numbers for these other things. Let's say mercury. And you know, at 80, which is above 60, you're still going to have a good saturation. We said that saturation doesn't start to really fall until the PO2 drops below 60. So at 80, you're still going to have a good saturation. So when we perform blood gases on this patient with narcotic overdose, we'd see numbers perhaps that would look like this. Now, when you get these numbers back from the lab, when you interpret blood gases, the first thing you do is you look at the pH. That's number one, to determine if you have an acid-base disturbance. So you ask yourself, is the pH between 7.35 and 7.45? It's not. It falls out of range. Is this an acidosis or an alkalosis?
Acidosis.
This is an acidosis. Step 2 in interpreting blood gases. Next, look at the PCO2. Okay. In the face of an acidosis, if the CO2 is high, then it tells you that acidosis is respiratory in origin, that the person has a respiratory acidosis. Okay? What it tells us is that the patient's holding on to CO2, and that elevated concentration of CO2 is reacting with water, forming an acid, a respiratory acid, that releases free hydrogen. Okay? So in respiratory acidosis, you have this effect, the scarecrow effect, where CO2 climbs, pH drops. Now, we're going to leave bicarb alone for now. But the fact that the PO2 is above 60 tells us that the saturation is going to be above 90. Okay, I pointed that out on the oxyhemoglobin association curve earlier. In fact, I'll tell you a little secret. If you're in a hospital and they need to monitor the oxygenation of your blood closely, instead of doing an arterial blood gas every 15 to 30 minutes, which would be cruel and unusual punishment, they put a device called a pulse oximeter on your finger. Okay? And this uses colorimetric method to assess the PO2 of your blood based on the color of the blood beneath the nail. Why? Because the more saturated your blood is, the pinker the hemoglobin. As hemoglobin desaturates, the nail starts to become darker or more blue in color. Okay. Now, so the pulse oximeter, this little device, will give you information with regard to SaO2, and it will also give you the pulse of the patient. It can measure the pulse. Typically, these devices can have an alarm that can be set. The alarm can be set to go off if the SaO2 saturation falls below 90%. Why? Why is that important? Let's go back. Here's the hemoglobin saturation of 90% right here. It correlates with a PO2 of 60. If the PO2 of 60, if the saturation falls below 9%, we're entering onto the steep part of the curve. Okay? But is rapidly desaturating. It tells us that the PO2 is dropping below 60, which is a critical area. Okay? Generally, a PO2 of 50 or less is considered respiratory failure. Okay? So we want that along the sound if the saturation falls below 90, because that correlates with a drop in dissolved oxygen content below 60 millimeters mercury. And again, 50 is respiratory failure. So we're heading toward failure. Someone needs to be alerted. Okay. Now, the same thing could happen, by the way. Someone could develop a respiratory acidosis with a brainstem injury that suppresses or damages the respiratory center. Okay, so it doesn't fire, so that we don't ventilate. We stop ventilating the way we should. Why? Because the respiratory center is in the pons and dual control ventilation. Okay. You can also develop respiratory acidosis in the face of severe bronchospasm. Why? Because the more severe the bronchospasm, the higher the airway resistance. It impacts movement of air into and out of the lungs. If we can't move air out of the lungs, we can't excrete or get rid of CO2, and it will build up. So in severe asthma, patients develop a respiratory acidosis. CO2 builds up because they can't get rid of it. They can't ventilate. They can't move air. And so they develop this type of clinical picture. Now, you can develop airway resistance as a result of asthma. That's usually reversible. Or COPD, chronic obstructive pulmonary disease. That leads to airway narrowing, but it's less reversible. If your airways are narrowed, it impacts ventilation, movement of air. So that if there's decreased ventilation, CO2 climbs. You develop a respiratory acidosis. Everybody with me on that? Okay. By the way, after I turn up here, FiO2 is the inspired oxygen content. Okay? If we're breathing room air, the FiO2 is 21%. That means that oxygen makes up 21% of that mixture of the inspired air that we're breathing, the room air. Okay? situation like this, where here's the alveolus. Here's the surrounding pulmonary capillary. And between the two, there's a buildup of fluid, known as pulmonary edema. Well, that respiratory membrane is going to become markedly congested, and that can impact the diffusion of oxygen from the alveolus into the blood. Okay. In fact, this is what happens in congestive heart failure. People develop pulmonary edema, and as a result, they become hypoxemic. Hypoxemic. Their PO2 drops below 80. Sometimes it drops below 60. Okay? In other words, there can be a critical drop in PO2. So what do? We can increase their inspired oxygen content. Instead of giving them room air, we can put them on what's called a veni mask, which has a richer oxygen content within the mixture than does room air. So, for instance, we can order a veni mask with an FiO2 of, let's say, 30%, or 40%, or 50%, meaning that the oxygen content of that mixture is higher than atmosphere. Instead of being 21%, let's say it's 30%. Okay? Does that make a difference? Yeah, because that means that more oxygen is going to reach the alveolus. In fact, I can figure it out. I can figure out the new PaO2, the amount of oxygen in the alveolus, by using our equation. 760 minus 47, but instead of multiplying times 21%, I multiply times 0.3. And then I'd subtract whatever the PCO2 was over 0.8. Okay? But you can see, because I'm multiplying times a higher oxygen percent, then the PaO2 is going to increase. And if I have a higher PaO2, I'm going to draw more oxygen into the blood. So we do that all the time. If someone's hypoxemic, we put them on supplemental oxygen.